Okay, guys, today we're going to go over some basic biomechanics. So these are our course objectives. We're going to explain the three laws of motion and define torque and differentiate types of torque. We're going to identify and explain the different types of levers as they relate to the body. We're going to identify joint movements with appropriate terminology. We're going to identify the anatomical planes of motion for each joint motion as well. So we're going to start with some simple definitions. So biomechanics is we're applying principles of mechanics, the study of force and motion, to function to the human body. Then we have kinematics, which involves the time, space, mass, and aspects of moving systems. So forces causing certain movements. So we have different types of kinematics. So we have osteokinematics, which is the movement at a joint. And then we have arthrokinematics, which is the interaction between bones of a joint. Kinetics in general is the forces causing actual movement as well. Some more definitions is the idea of force is the push or pull on an object. Then we have mass, which is the amount of matter a body contains. Then we have a term known as inertia, which is the property of matter to resist. And then that's delta, which means change in motion. So anytime you see that delta, we're going to be referring to change. So inertia is the property of matter to resist change in motion. That's either in speed or direction. Then we have torque, which is the tendency of force to produce rotation around an axis. So what muscles do to the joints. And there's two different types of torque. There's static torque, which is where the start of an object begins to rotate. Then there's dynamic torque, which is the force needed to continue that rotation. Then we have friction. So friction is the force between two surfaces preventing motion across each other. So think of cartilage on cartilage, which is less friction than ice on ice. And then you have bone on bone friction. The same joint has significantly more resistance to movement. So think of your bone on bone as those clients who are having knee issues or hip issues. This is typically a sign of when you need to get like a knee replaced or a shoulder replaced or a hip replaced, those type of things. So we have three laws of motion. So these were all three of them were developed by Isaac Newton. So we have the first law, which is the law of inertia. So an object at rest tends to stay at rest, and an object in motion tends to stay in motion. The force needed to overcome inertia to move, stop, or change direction. So down below, think of coup injuries and contra coup injuries is an example of the first law of motion. So coup injury happens at the site of the impact. So think if you have a limb affected, it's only going to affect that area of the limb. Then you have your contra coup injuries, which are your injuries that occur opposite side of the actual injury site. So think of your stroke patient. So if you have a right-sided stroke, it's going to affect the left side of the body and vice versa. Then we have the second law, which is the law of acceleration, which is the amount of acceleration depends on the strength of the force applied. So acceleration changes when there's a change in velocity of an object, and this is going to depend on the strength of the force applied as well as the mass of the object. So think of someone throwing you a lighter ball versus a medicine ball, and think of the force that you're able to get with a lighter ball versus a medicine ball and how much strength you need to actually throw that ball to the other person. Then we have our third law, which is the law of action reaction. So for every action, there's an equal and opposite reaction. So with this, think of an example of bouncing a ball. So the more force you put on the ball, the higher it's going to bounce, and vice versa. So then we have force couples. So this is when two or more forces act in different directions. This often results in a turning effect. So some examples are that scapular rotation up here. When the upper and lower trapezius, as well as the serratus anterior, are interacting with one another is when you're going to get that rotation effect. So that crossbody arm or even for anyone that played a sport requiring you to throw, you're going to get that rotation. You also have pelvic posture, which is where the erector spinae and the sartorius interact with one another to incorporate that anterior or posterior pelvic tilt to help with body posture. It can also aid in joint stability, which we'll touch on in the next slide. This is with the subscapularis and the infraspinatus, as well as the JRF. The JRF is the joint reaction force. So that's the joint reaction force based off of these two interacting with one another. So again, with the subscapula, it does internal rotation, IR, and the infraspinatus does external rotation. So alone, they cause movement in the one direction. So your subscapularis is in charge of just that internal rotation of the joint, and then your infraspinatus does the external rotation of that joint. However, when they work in tandem, there's no movement, but it's a stabilizing and compressing force. So that's what keeps your shoulder where it is, and it prevents it from moving back and forth. So anytime we have like a subluxed shoulder, we'll typically have an issue with one of these. So then we have relevance to the upper extremity range of motion. We must look at a scapular mobility, not just the humeral mobility. So we must look not just at that one side causing that movement, but we should look at both sides. So we should address and figure out their scapular mobility, not just the humeral mobility. There could be some issues there. So then we're going to talk about torque. So torque, aka rotary force. So it's the ability of force to produce rotation around an axis. So we're looking at the amount of muscle contraction needed to create joint movement. So what this looks like in the body. So we have the strength of the muscle with the contraction. Then we have the movement of the moment arm, which is the perpendicular distance from the line of pull to the axis of rotation. This is also influenced by increased force and the increased handle as well. So muscle most efficient to move the joint is about halfway through range of motion. It's less efficient to start at the beginning or the end of the range of motion. Because of this, some muscles are better at stabilizing the joint than moving the joint in general. So what this looks like in the body, we have the position of the joint moves the muscle closer or further from the axis, which can either decrease or increase the length of the handle. So for example, the elbow in extension, the force is more through the joint and stabilizes the joint. However, in 90 degrees, there's a greater moment arm, and that lends itself better for and more efficient movement. In the flexion, there's a shorter arm, and that's a dislocating force. So when we cover manual muscle testing or MMT, we will typically start testing at 90 degrees. This will be something that we will start working on later this semester. Just remember the length of the handle is denoted by M, or the quote unquote motion arm. So again, what this looks like in the body, we have our patella, which is that knee cap area, moves the tendon away from the bone, increasing the movement arm and the movement in general. Without the patella, the quads would have to stabilize the joint, and then there wouldn't be any movement in that joint. So then we have force arm, moment arm, lever arm, and torque arm. So the longer the lever arm is the distance between the force and the fulcrum. So the fulcrum is, think about where you're pivoting and where that lever turns. The less force required, but the further you have to move it. So how does this apply when performing range of motion for shoulder abduction, as you're seeing in this image? So if we move the patient's elbow, you have to use more force but shorter distance, versus if you move from the patient's wrist or distal forearm, you need less force, but you need to move further. So think of the amount of movement you physically have to do for the range of motion with the patient in this scenario. So then we have some stability. We're going to go over a couple terms. So we have the center of gravity, which is COG or COG. It's the balance point of an object or a person at which torque is equal on all sides. Then we have base of support, or BOS. A lot of you guys are super familiar with this after documentation. This is the part of the body in contact with the supporting surface. So just know that a lower center of gravity is more stable, and center of gravity must stay within the base of support to be stable. So therefore, a wider base of support, you're more stable. This is kind of why in our previous lecture of body mechanics, that's why we want to take a wide base of support to support that. So how does this relate to forward head posture, kyphosis, and scoliosis? So think of when you're, and I'm really bad about this, but think about when your head, when you're typing, doing whatever work at a table, and your head is kind of hunched over. Think about what that does issue wise with your bike or with your back. It could cause some kyphosis, some scoliosis as well. So that's why it's always recommended to take breaks when you're sitting at a desk for long periods of time, especially with some simple chin tucks, some simple neck stretches, and stuff like that to really support that. Um, and also remember, people moving have better balance if focus is on a stable object. So think when using a front wheeled walker, crutches, or another assistive device, we're not asking the patient to look down at their feet. We're really encouraging them to look forward. I will tell you that most of your patients will want to look down at their feet to see where they're going. But if we can encourage them to look up, there would be an increase in balance. So now we're going to talk about things that change force. So we're going to look at levers, so an increased power or distance moved. So we're going to look at these different things. So we have resistance, also known as load. We have our axis, also known as our fulcrum. And we have our force, also known as effort, which is also correlated to the muscle effort. So in the body, there are three different classes of levers. They're pretty simple: first class, second class, and third class. So a first class lever, the fulcrum is between the force and the resistance. So your fulcrum is like right in the middle. Think about it like a teeter-totter. So you have your force and your resistance. This favors balance. And an example of this is your head on your C1 vertebrae. In your books, you can see page 29 as an example of that, but this is an example of your first class levers. So then we have our second class levers, which there's very few in the body. So second class levers are the resistance in the middle, the fulcrum's at one end, and the force is at the other end. And this is in favor of power. So think of your plantar flexion. So kind of that push up. Um, and then we have our third class levers, which are the most common in the body. This is when your force is in the middle, your resistance and fulcrum are at opposite ends. So this is a favor of speed and distance. So need for range of motion and speed more than power is typically. Again, this is the most common type in the body, and think of that elbow flexion. So that elbow flexion is a very good example of that. So with patient transfers, levers increase the power that you're able to do with the patient. So what type of lever is the patient using right now, or is the therapist using right now? Any ideas? So it's actually becoming a third class lever. So by blocking the knees, the femur becomes a third class lever, allowing an increase in power, which equals more, you're able to move more weight with less force than would be needed to lift the same amount of weight. So we'll learn more about this with function as it relates to transfers in Human Occ 1, as well as in your fourth semester classes involving transfers and how to use your leverage or your levers, so to speak, to support more transfers and more accurate transfers. Good body mechanics, by the way. Someone said levers can also work against you. So levers increasing the power. So the longer lever arm, it means more force exerted at the fulcrum. So think about it this way: this is an older adult versus a younger child. The amount of work the therapist has to do with the older adult due to its length of lever is going to be increased or more than the therapist working with the smaller kiddo. Any idea of what types of levers this could be? We'll hold off on going over this and you guys can tell me during class. So then we have our caregiver is stepping on a post on back of wheelchair to help client up to the curb. Where would you place these current symbols? So F down is going to be our force. L is going to be our load. And this F with the delta is going to be our fulcrum. And also, what class of lever do you think this is? So I'm gonna give you guys a couple seconds for that. So with this, so it's a first class lever. So our force is going to be the caregiver's foot pushing down onto the wheelchair to get that tilt. Our fulcrum is going to be that post that we're pushing down on. And then our load is going to be the person in that wheelchair. So we're going to talk about pulleys, which is a change in direction of a force or increase or decrease in its strength. So think of finger pulleys. So what you're going to do is you can have your hand supinated and you can kind of see your finger as you move it up towards your wrist. So finger flexion, you're going to see that finger pulley, and then your lateral malleolus as well. So we have inclined planes. This looks like fun, right? Looks like a lot of work. So with inclined planes, we're trading an increased distance for less effort. So we need a greater distance for wheelchair to travel, which will require less effort of a user. So think of your ADA, so your Americans with Disability Act and the wheelchair ramp standards that they require in most homes or most buildings, commercial buildings. So you have a 1 foot to 12 foot slope, or sorry, 1 inch to 12 inch. So every inch of rise, you must have 12 inch of ramp. Um, and that's super helpful to decrease the load and the effort that the patient has to give. And that, my friends, is the end of this lecture. What I'm going to do is I'll put together some review questions when you guys come back into the class for the next lecture. And we'll kind of go over this as well as wrapping up any questions or anything that you guys have for me, as well as an answer to that question on that slide. I hope you guys have a great rest of your day, and I will see you guys next class.